The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for the last day of March 2021. This is Deanna Mitchell from Leading Age Michigan. Just a few weeks ago, it seemed we were looking at the downside of the pandemic, and at least we were anticipating pretty much the end of it for most issues by the end of this year. However, cases in Michigan are increasing significantly again, even if the caseload in long-term care facilities has stabilized at fairly low numbers. Some experts are saying that we will not be able to outrun the variants, and we will have to keep vigilant for quite a while. So this morning, we have invited two representatives from Omnicare to provide a brief update on vaccinations, and then we're going to follow with our standard agenda. Dalton will provide a brief advocacy update. We'll take a quick look at the numbers, and then we will discuss the March 29th CDC updates for nursing homes, which of course impact other settings as well. So at this point, I'd like to introduce Matt Garlick and Nancy Losman from Omnicare, who are going to give us a brief update about the vaccinations in Michigan. Welcome.
Thanks, Deanna. Good morning, everyone. This is Matt Garlick speaking, sales executive with Omnicare for Michigan. Nancy and I appreciate the opportunity to join today's discussion. As Deanna said, we'll provide some updates on the continued vaccine support for Omnicare customers. But first, I thought I'd quickly share some updated figures related to the ongoing efforts in vaccinating the long-term care space specifically. As of today, we've administered over 4.5 million doses to both residents and staff in over 40,000 long-term care facilities across the country. As of today, the series of clinics are complete in skilled nursing facilities, with assisted living not far behind. Second clinics in assisted living are 99% complete, with 95% of final clinics completed as of today. Since these efforts began, we've seen a 94% decrease in COVID-19 cases and an 84% decrease in deaths, according to data provided from the CDC and CMS. So trending in a positive direction, I think, all things considered. And with that being said, I'm going to turn it over to Nancy Losman, our Chief Quality Officer, for some updates on how we intend to continue to support our customers in vaccine strategies moving forward.
Well, thank you, Matt, and good morning, everyone. Thank you for joining the call. We certainly appreciate your attention. I wanted to introduce you to Omnicare's two-part plan to deliver vaccines to our long-term care customers. Our programs are dedicated to those facilities who currently have contracts with Omnicare for routine pharmacy services. Omnicare has enrolled as a federal provider through the CDC for vaccines, and we will begin to distribute them as soon as we shore up a little bit more of our processes and we have received the vaccines from the CDC. We expect that to start in the next couple of weeks. The intention of this program is for Omnicare to receive the vaccine without having to go through the state. It'll be directly delivered to Omnicare, and we will distribute that to our customers based on routine deliveries. At this time, we're not certain which vaccine will be provided, either Moderna or the Janssen or J&J product. We're hoping that it is the J&J product, so that only 5 doses at a time would need to be opened in a particular vial. It is intended for the nursing facility, the assisted living facility, or the independent facility who has resources to administer the vaccine. Omnicare will not be administering the vaccine under this federal program. It is only a distribution. Of course, the vaccine itself is of no charge to the patient or the facility. And in the kits that will be delivered to our customers, they will be receiving everything that's needed for their staff to administer the vaccination, including things like the wipes, the syringes. And in addition to that, we'll be providing the vaccination cards, vaccination records, vaccination information sheets, the emergency use authorization materials, and our clinical nursing staff will be providing additional resources for our customers that will support additional training, how to use the forms, how to complete them. But most of our customers are very familiar with all of this already due to the clinics that were provided by CVS. I do want to note that CVS has registered with the CDC as a separate company. The vaccines that were administered during our clinics were provided by CVS Retail. This is an Omnicare long-term care pharmacy, a different company owned by CVS that'll be involved in the distribution of the vaccines to the nursing facilities. It is also anticipated that Omnicare will be receiving back from each of our customers the vaccination information so that Omnicare will be loading the data into your state database. And we have applied for the access to your state vaccination databases and are using even a third party to help us with that application and facilitating it so that we can begin distributing the vaccine as soon as possible. This is a measure to help maintain vaccinations after the clinics are over. However, it is important to note that Omnicare will not be providing a fourth clinic for those patients or residents or staff members who still need a second dose. This is not a second dose program. Please look to your state agency for assistance with the interim doses that would need it to complete the dosing regimen. In addition to this, we understand that there may be independent living customers or those who may not have 24-hour access to immunizers or vaccinators in your communities. And with that, we are offering to our customers and have already provided information on a toll-free number that they may call. And with that number, they can assure a block of appointments at a nearby CVS retail pharmacy for all ambulatory patients who can make it over to the CVS pharmacy, including your staff members, ambulatory care, and anticipate that, for example, if you have a van or you have a bus, that you can transport your residents and your staff members to a CVS retail site in one block of time, and they will be given the white glove service, as we like to call it, where we will immunize them all at one time, perform the needed observation for the community, and then they may return safely back to the center. At this point in time, we're working with each of the states to see how we can help them with the interim vaccines and where you may be able to locate them for those that need that second dose of their regimen. We hope, again, that the J&J is what we'll be receiving. I think everybody would enjoy having a single dose administered to their residents rather than the two-step or the original and a booster dose. So with that, we're hoping that this will ease your concerns regarding the maintenance program. And again, if you have questions, Matt and I are here either on the chat line to respond to your questions. This is, again, one of those programs working with the CDC and a federal program that allows Omnicare to maximize professionally the program uniformly across all of our pharmacies over all of our states to assure that we have a single process in place to deliver and distribute the vaccine with the proper storage conditions and all of the accessories that needed for that vaccination uniformly, accurately, and correctly to each of our customers. And with that, I will turn it back to Matt if he would like to add anything.
Thank you so much, Nancy. I think you covered it all. I don't know if we want to open up for questions, but I think we did a good job covering all the nuances that we're expecting with the go forward strategies here.
All right, thank you to both Matt and Nancy. We do just have a couple questions, so I'll just get right into those. Is this program only for your existing customers?
Yes, it's a great question, and thank you for it. Yes, this is only pertinent to those who have an existing pharmacy services agreement at this time, although we would certainly welcome any new business if you should want to use Omnicare as your provider pharmacy.
Okay, thank you. Will we be able to use this for staff too, or just residents?
Thank you again for the question. This would be for all those in your facility, including staff members who wish to be vaccinated. We do understand that there are some staff members, perhaps not in the nursing department, that may have been a little more reluctant to receive a vaccine during the current clinics that are now coming to an end. Those patients, especially if they're in the non-nursing departments, are certainly welcome to participate in this program, as well as get those appointments, if you would like to make them for that staff, at our CVS retail pharmacies. We know that now that they see the safety of the vaccine, where we're looking at severe allergic reactions, maybe 2.5 to 11 per million doses administered, that they feel comfortable now. They realize that they would like to protect their family. And in some instances, if our staff in our nursing facilities wish to leave the country to visit home, they may very well need to be vaccinated before they can leave the country. They may also need to be vaccinated before they return to the country.
Okay. When should we expect to hear more about receiving those vaccination kits? Do we need to officially ask to receive them, or will you be reaching out to us?
It's another great question. The process will be laid out for you so that you can, when you have, let's say, 5 patients or increments of 5 or 10 patients that need to be vaccinated, you would use the purchase order system that Omnicare has in place and order your vaccine in advance of the day you wish to have your clinic. That morning, or with the closest routine delivery to the time you want to administer the vaccine, Omnicare will deliver the vaccines to you in your facility. So they'll be coming inside to deliver the package directly to the facility to maintain chain of custody. Once we deliver the vaccine, you are free to administer that. That same day, you will fax back to us the vaccination record so that we can input it into the state database within 24 hours. The nursing facility will be responsible to report any adverse reactions to the VAERS program and to record any wasted doses that were unused in the facility.
Okay, thank you. It looks like we have one more question here. Where do we get our second doses for people that received the first dose on the 3rd clinic? The pharmacy says to ask the health department, and the health department says to ask the pharmacy. The only luck we have had is calling local pharmacies and getting leftover doses in the evening. We also do not have a CVS pharmacy near us offering the Moderna vaccine.
Okay, well, thank you. It is a conundrum across every state. I must tell you, the greatest issue right now is obtaining that second dose for those that have been vaccinated already. Luckily, what we have seen is that the extended time to receive the vaccine is now up to 42 days. That doesn't necessarily solve your problem. Unfortunately, there are some state representatives that just don't understand the difference between Omnicare and CVS, and that Omnicare did not provide the clinics. We are seeing across many of the states that the health department is actually administering these vaccines. If we talked to other states where members of the Department of Health or FEMA or the National Guard are coming into nursing facilities to administer those doses. It is difficult, but I will tell you that if you can build a relationship with a nearby pharmacy that is registered as a state provider, and remember, Omnicare is a federal provider, you can go to your state website and look for a list of pharmacies registered as state COVID vaccine providers. If one is close to you, call them and find out what they can do to help you as an individual facility, whether you're an Omnicare customer or not. This is where we're finding that the best source of the second dose for your staff and for your residents.
All right. Thank you very much to both Matt and Nancy for joining us today, as well as obviously the whole Omnicare team. With that, I believe that was the last question. So we will go ahead and move on to our normal agenda. So we will turn it over to Dalton Herbal for advocacy. Thank you.
Good morning, everyone. We should just have a fairly quick update this morning. A couple of things going on in Lansing. First of all, quick update to the legislative schedule. The legislature is going to be out for an in-district work period for the next 2 weeks. Upon the return, they're going to be looking at the budget, the FY 2022 budget, trying to get those negotiations settled within the next 3 weeks. When they return, their deadline is October 1st of 2021. We're pretty hopeful for these discussions this year. Unlike the last 2 years, the governor's budget recommendations had no funding cuts or funding restructures for long-term care providers. There's also $10.6 billion roughly coming from the American Rescue Plan to the state. I think 5.5-ish to the state itself. The rest will be going to local municipalities. And if you have any questions about the American Rescue Plan, we have invited Marsha Greenfield, and she will be at our Finance and Strategy Day coming up. And she is with Leading Age and has been kind of instrumental in Leading Age's research and policy making with the American Rescue Plan. So she'll be good to have there. Another update, some of you may have already seen this in some of our communications. Laura is starting a regulatory burden task force. Director Horvath reached out to all 3 associations to create 4 committees to look at Michigan's regulatory burden for nursing home providers. All 3 associations will be present, and Leading Age, ourselves, we have member representation on every one of these committees, and I'm really happy to say that we have a large amount of representation on the Quality Improvement Committee. I think that's important. The 4 committees are citation patterns, requirements of statute, and the unnecessary enforcement of them, facility reported incidences or FRIs, and quality improvement. Just a quick update on direct care worker reimbursement. I think it was last Friday, MDHHS released a updated reimbursement form for you to use when submitting your costs, and this is specifically for SNF providers. I did have Blake upload that to the handout section of today's webinar, so that is the Word document there that you'll see. We did reach out to the department, and they were able to tell us that the new overtime rate for SNFs, because of the increase in overall payment, is going to be set at $3.38. Additionally, MDHHS is still working on finalizing the guidance for HFA and AFCs. I know this has caused a lot of problems for a lot of people since the language is very broad in general, and the other guidance for SNFs is very prescriptive. So we are working with the department to get something done. They did let us know that they did not anticipate it getting out this week. So hold tight on that one. Lastly, we are Leading Age National is going to be holding a virtual advocacy day that is free for all members. This is our chance to connect with our national level representation, our national representatives and senators. This is set to replace the peak advocacy conference or leadership conference, depending on how they decided to brand it. The registration link is on today's slides and is right there. There will be, the actual meetings will take place April 21st between 9 a.m. and 4:30 p.m. Leading Age is scheduling those meetings for us, so we don't know the exact times of the meetings, but they'll be between there. And then on April 14th, Leading Age will then let us prep, have a prep day for the Advocacy Day, giving us a lot of advocacy materials and a brief overview of how to talk to national level representation. And then after the 14th, Michigan members will coordinate together once we have the schedule of our calls to see who can attend what call. There is no expectation that you attend the full day or all the calls unless you want to. So please feel free to join us for that day. We already have a couple of members registered, and Leading Age Michigan staff will be there as well. So we're pretty excited for this opportunity.
All right, thank you very much, Dalton. We do have a couple questions, but before we do get into any questions, I'm going to pull this up on the screen here. Just wanted to give everybody a reminder, if you do go ahead and go over to our website, if you click on the events tab, you will see we have our SNF Regulatory Day coming up in about 2 weeks here, April 14th, and we have a couple other courses that were just added as well. We have our Housing Matters program, which is going to be at the end of next month, Thursday, April 29th, and registration is open for that as well. And we also have our Assisted Living Conference on Thursday, May 6th, and that was typically called our ALHFA Day if you were looking for that. That is now called Assisted Living Conference, so you can go ahead and register for that there as well. So now let me go ahead and pull up some questions. Where can we find an updated direct care wage pass-through reimbursement form for AFC providers?
There is no form for AFC and HFA providers at this time. The department is still working on it. We have been in contact with them almost daily to try to see where the progress is, but they have said that they're behind in creating the documents for HFAs and AFC providers.
All right, well, I think that pretty much answered this next question, but I'm just going to ask it anyways. How long do we keep waiting for responses from MDHHS on the AFC HFA piece? The response seems very slow in coming. When may we have direction on this?
Last I spoke with them, which was yesterday, they said that they will not have it by the end of this week. So we will see. They just keep insisting on holding us tight, holding tight. There is, the reason for the delays is essentially because of Lansing politics. The supplemental budget that expanded the program to HFA and AFCs was not reviewed by the department before it was implemented. So the department, this kind of was sprung on them. And then there is now some concern that the funding pool that was originally set may not be enough. So they're working through a number of issues here. They're being very vague in communications with us, but we are working on it.
All right, thank you very much. It looks like that was the last question for you, Dalton, so we can go ahead and move forward. Deanna, I do have a question regarding visitation. Did you want me to hold off on that, or?
Yes, hold off, please, on that.
Okay.
So thank you, Dalton. We're going to, as usual, take a quick look at the numbers. Since our last webinar on March 19th, unfortunately, both the average daily caseload rate and the death rate in Michigan have doubled. We're now averaging 1.4 deaths per 100,000 persons over the past 7 days as of the CDC numbers that were posted yesterday. At this point, over 17,000 persons in Michigan have died, and we've had 32,000 new cases just in the past 7 days. And overall, just over 723,000 cumulative cases, which at this point is about 7.3% of the entire Michigan population. These are the CDC Map Updates, and you can see starting on the far right and then moving to the left that Michigan's caseload rate per 100,000 persons averaged over 7 days. That number has grown immensely since February 8th when we first posted this graphic. As of yesterday, only one state had similar caseload rates, and that was New Jersey. But as of this morning, New York and Connecticut are also now in that dark blue range. So we're not the only state that has increasing numbers, but we are at the forefront of that group. In terms of variants, as of yesterday, the CDC continues to report that Michigan is second only to Florida in the number of variants. We currently have over 1,200 cases of the UK variant and 5 cases of the South African variant. I keep hoping that's because we test more for the variants, but I'm not 100% sure of that. Here's our standard caseload map, and you can see the rather dramatic incline in the number of daily cases averaged over the past 7 days. And this data was recorded as of yesterday morning. So we're seeing a lot of increase just over the past week even. And as we said earlier, there has been a slight increase in deaths. You can see a small spike there, although it has come down a little bit since then. The numbers still seem to be fairly stable over time. We're hoping that the death rate will not increase at the same rates as caseload, since many of the seniors and elders who are the most vulnerable are now vaccinated. So we're hoping the death rate will not spike like the caseload does. And those same increases can be seen in the CMS county transmission rates as identified here. You can see a sharp increase in the red category and also the more moderate yellow category in terms of transmission, with an associated decrease in the number of low transmission counties at this point in Michigan. The numbers in long-term care facilities have continued to be low, although we did happen to see an increase in the number of new resident cases in skilled nursing based on the state weekly reporting from Monday. So I think it was something like 50. I have the number in a later slide. HFA cases, though, remain stable at a very low rate, so those numbers are looking good. And cases in AFCs actually continue to decline a bit, so that's good news as well. Here's our table describing the new and cumulative resident and staff cases in Michigan facilities. New resident cases in nursing homes did double since last week. We noted that several of the facilities who had outbreaks of like 6 to 8 people. So it wasn't necessarily a large number of facilities, but there were significant outbreaks in a few of them. The thing that is a little disconcerting is the staff case rate has grown and also more than doubled over the past week. So although we are seeing pretty good numbers in terms of residents, the staff numbers are continuing to concern. I threw this in here because it just confused me so much. This is a CDC map describing the vaccination rate per 100,000 persons by state. And the information directly on this page stated that Michigan had vaccinated about 4.2 million persons. But when you click on the state and you get into other CDC pages, we got a whole lot of different numbers. And they were all links based on this map. So you can see I put some of the numbers to the right of the slide. So it's kind of hard to determine where we really are. But the CDC also reported that we've vaccinated 31% of the over 8 million adults in Michigan, so that's good. And this morning, the state reported that we had vaccinated about 4,207,000 persons. So considering that we only have a population of just under 10 million persons, those are pretty good numbers. In looking at the Federal Pharmacy Partnership Program, about 100,000 persons, including staff and residents in long-term care facilities, are fully vaccinated, and there's 184,000 about working toward a second dose. And this data came from the CDC on Monday. So, okay, let's move on to updates and guidance. We're going to focus on the CDC updates that were published on Monday. This first piece made the news several times on Monday, and it came from a morbidity and mortality weekly review. And the important piece was that it identifies that not only do vaccines stop persons from becoming ill, which is all that they were really tested for in the beginning, they also appear to stop persons from actually contracting the disease as well. They noted 80% effectiveness after the first dose, that increased to 90% effectiveness with the second dose. And of the few persons who did contract the disease after becoming vaccinated, a little bit more than 10% were asymptomatic. Additionally, the CDC updated their review on comorbidities in terms of outcomes of COVID. The strongest factor, as we would expect for death, was very old age. Only about 30% of persons coming to the hospital had no comorbidities. And overall, 20.3% of persons admitted to the hospital for COVID end up dying there. The type and list of comorbidities have not changed much with this update, although the diagnosis of cancer seems to be the factor most associated with mortality. And of course, the more comorbidities a patient has, unfortunately, the greater likelihood of death. So now this is the rather large CDC update affecting nursing homes. And of course, it also affects other residential long-term care facilities as well. It is labeled the Interim Infection Prevention and Control Recommendations to Prevent COVID Spread in Nursing Homes. And it is a merger of two former documents for nursing homes. One labeled Responding to COVID-19 in Nursing Homes and Performing Facility-Wide Testing in Nursing Homes. And it's important to note that this guidance continues to be a supplement to the general CDC infection control guidance for healthcare personnel, which covers the general rules across all healthcare settings. And I have the link to that on the page there. One of the key statements in this updated guidance is that although residents are often vaccinated, there's still quite a bit of risk. And generally, facilities have to be very vigilant on an ongoing basis. Safety precautions are still all required, whether or not you have current cases in your facility. And unless the CDC guidance specifically notes otherwise, all of the same rules apply, regardless of the vaccination status of an individual or the actual amount of vaccination coverage in your facility. So not only does the new guidance merge the former two documents, and it doesn't actually add a lot of new information, but it does clarify and provide a little bit more detail about a lot of issues. At this point, during the pandemic, we see fewer and fewer major changes in the guidance, but we do see a lot of subtle changes and clarifications come out. So sometimes it's actually even harder to track because it's not a major change, just a lot of nuances. What's in front of you now are all the sections in the combined guidance. And again, a lot of those larger topics have not changed. But what we're going to do, starting in the next slide, is we're going to go through each section where there have been updates to it only. The first change didn't really feel like much of a change to me. It was basically to ensure that the language for notifying the health department what's consistent and in alignment with the Council of State and Territorial Epidemiologist guidance for reporting, excuse me. So the language here is consistent with MDHH reporting requirements now, but we've not talked about some of these requirements for a long time. So this is kind of a reminder that you not only have to report suspected and confirmed COVID cases, but you're still required to report persons with several respiratory infections, severe respiratory infections resulting in hospitalization or death, or when there are 3 or more staff and residents that come down with COVID-like symptoms all within 72 hours. So those are things that we haven't talked about in a long time, but they are still required. The requirements for notifying staff, families, residents have not changed. And of course, NHSN reporting is required, and that has not changed either. The next section focuses on the need to encourage vaccinations for staff and residents on an ongoing basis. There are links to CDC resources in this section to assist with that. And they want to encourage facilities to try to facilitate vaccination of staff, even though the pharmacy partnership program is pretty much over. There are some changes in the language in the rules for visitation and physical distancing, but these updates are really mostly intended to align with the updated CMS visitation guidance, and it refers back to that actually in this section. And it also refers to the CDC updated recommendations in response to vaccines. That piece is one that we went over at our last webinar, and that is the CDC guidance that came out at the same time and was linked to the QSO 2039 nursing home. The rest of the narrative around visitation and physical distancing is not really new. It does continue to speak to the need for planning visitation carefully and applying all the safeguards and notifications to keep everyone up to date. The next area is an added section on the proper use and handling of PPE. Obviously, each facility is expected to have policies and procedures in writing that define the situations where PPE is needed, what kind of PPE is required for a given situation, and the proper sequencing for donning and doffing. We do know that staff errors in donning and doffing is an area often cited by nursing home surveyors. Policies and procedures must also address the proper care of reusable PPE, and also a reminder to bundle activities to minimize staff moving in and out of rooms. CDC optimization strategies when PPE is scarce continue to be in place. And this section has links to other CDC information and resources on PPE use. They also added a section called Universal PPE Use, so that the information for nursing home aligns with the general infection control guidance for other healthcare settings. And the focus in this section and the new pieces in this section is really about the fit of the mask. Also in this section, they've included old language that talks about the expectations for facilities who are in moderate to substantial transmission areas, as well as for those in low transmission areas. This really hasn't changed, but we found it a bit confusing on when it was first published, and it's still a little bit hard to figure out at what point you might be able to relax some of the PPE requirements. So when this was first issued, Laura was taking the stand that the entire state was in moderate to high transmission. So even if infection was not suspected, at a minimum, a well-fitted face mask would be required. There is additional and newer language here that speaks to the fitting of masks and how to address masks with loops, links to information about improving fit, and the need to ensure staff are trained on fit. We also get a lot of questions about eye protection and if it's still needed. And the CDC guidance still says for moderate to substantial transmission areas, it is still required. But the difficult part of this language has not really changed. The things that we just talked about are those things you must do in areas of higher transmission. When rates started to come down in those lower areas of transmission, which we would assume to be less than 5% county transmission rates, it simply says you can do all those things. It doesn't really clarify at what point and which actions you can eliminate at any given time. So it just pretty much says you can do those things, which might include eye protection, N95 and PPE, and well-fitted masks if not using a respirator. And I have a line there that apparently I didn't finish, but there really isn't good information about at what point we don't have to use shields, etc. So we're going to try and continue to work with Leading Age and in their discussions with CDC to see if we can get something better there. Hopefully, we will be in a place where we have a lot of counties that remain in low transmission. There is new information about suspected infections and use of doors and closed doors specifically. Persons who have been suspected of having an acute COVID infection, under suspicion now, not necessarily confirmed, they should be at least moved to a single private room with a private bathroom until the results have been confirmed. And hopefully there's not a whole lot of time lag there now, since pretty much everyone's using point-of-care tests. Generally, as in all infection control guidance, doors for persons who are suspected of having an infectious disease should be closed unless the person has been cohorted in an area specific. In other words, if they've been cohorted in an area after being noted to be positive. But even for persons with positive tests, leaving the door may be a problem in dementia. So there is some discussion about the ability to keep doors open if absolutely needed for the safety of the resident. But they also say that then there should be facility actions to implement strategies to minimize airflow into the hallway. So you're going to have to consider what other actions you can take to mitigate transmission if indeed you're going to keep a door open. There's a new section about sheltering in place and facilities based on the availability of single rooms, or if a large number of persons come down with symptoms all at the same time, you can consider sheltering in place while waiting for test results. Residents with close contacts, regardless of vaccination status, must still be placed in 14-day quarantine. And we had a meeting with the CDC yesterday, and they confirmed that again. And the reason for that, even though healthcare professionals don't necessarily have to be quarantined, even if they're vaccinated, residents are at higher risk. The CDC, that was their stand. And so they still have to be placed in 14-day quarantine. Remember, we're talking about close contact. Somebody you know has had COVID and that they were within 6 feet of them for a total of 15 minutes within a 24-hour period. Of course, you only move them to a COVID unit if they're found to be positive, and for persons who are under quarantine for exposures, full PPE must still be used. There are some alternatives to quarantine that the CDC includes in this guidance, and it's not new. But the last I heard from Mdhh suggests that they do not acknowledge these alternatives. The CDC is saying if absolutely needed, you can keep persons in quarantine for 10 days rather than 14 as long as they have no symptoms. Or you could possibly remove them after 7 days if they have no symptoms and they have a negative test, as long as that at least one of those tests is done within 48 hours before the discontinuing day. At no point can you take them out before 7 days. You have to continue to monitor them, but again, if memory serves me, when we asked MDHHS about this alternative months and months ago, they said no. There are, you can move on, Blake. Oh, we're going to take a pause here. Even though I'm not through with this guidance, it just seemed like an awful lot. So we're going to take a pause and look for some questions.
Okay, thank you, Deanna. Regarding visitation and HFA, if a staff person tests positive for COVID and 100% of the residents test negative, can indoor and outdoor visitation begin immediately?
No, no. My understanding from the CMS guidance is that you have to identify what your affected areas are, and that would be based on where that staff has had contacts, where that staff works. If that staff person is not a direct care worker, that might take some consideration on your part. But basically, you have to identify the contacts and identify where your potential affected units are. Those are closed for 14 days following your last positive. If you get no positive results in residents or staff that are in non-affected areas, you can open the non-affected areas. But basically, once you have an affected unit, whether it be a resident or a staff positive, you are closed in that area for 14 days after the last positive test.
Okay. This one kind of goes back to Dalton. It's a direct care worker pass-through question. It says direct care worker pass-through document 3/1/21 shows $2 versus the $2.25 that we received last week. Which form do we use?
The updated form, I did notice that as well and let the department know that they need to adjust it. The one that is in the handouts here actually does the calculations right. So if you type in the numbers, it'll represent the $2.25, but actually on the form, it does say the $2.
Okay, thank you. I notice on reporting to both EM Resource and NHSN, they ask with positive residents if they were fully vaccinated, but they do not ask this about positive staff. We have had a fully vaccinated staff positive. Do you know how they are tracking this, if at all?
I cannot speak to whether NHSN is tracking that. It appears that they're not. I do think that I would definitely be reporting that to the local health department just to be sure that we're identifying the efficacy of the vaccinations. But I do not know of any special reporting for persons who test positive who have been vaccinated.
If there is conflicting language in the new CDC guidance with CMS or MDHHS guidance, which do we follow?
That's the question of the year, I have to tell you. We're going to talk about this a little bit later in the webinar, but I've been a little frustrated with all three of those entities. I would say it depends on what the guidance is, and it depends on who you are. If you're a nursing home, technically, for most things, the CMS guidance should hold. There are, states do have the ability to provide additional guidance, technically as long as it doesn't conflict with the CMS guidance. As we know, some of these things have seemed to conflict, and yet MDHHS seems to be able to be the authority in Michigan, and I think that there are conflicts still within all of this. So it depends on what it is. It depends on whether it is an extension of what CMS is saying or an extension of what the CDC is saying. The CDC pretty much, CMS expects those recommendations to be followed unless they have something specific in their guidance that overrides that. And it depends on what it is. If it's something like testing, if the state says you have to test weekly and the feds say you have to test monthly, generally you're going to have to test weekly because it is simply a more restrictive guidance, but it doesn't violate the CMS guidance. So I'm sorry to say it depends on what it is and it depends on who said it.
Did the CDC change the language about staff who have been vaccinated and elect to travel and such? The original CDC permitted 3 months post-vaccination for travel without the need for quarantine. Is there an update here?
I did not see an update. And I don't know, I did not see anything that talks to staff who are vaccinated. I did look at this because we talked about it last webinar, and I do have a slide about the travel requirements. We need more information about that. If there is a section of the CDC guidance that speaks to vaccination for staff, please send it to me. I looked this morning and yesterday for that. And all I could find was their basic guidance for travelers, not even healthcare travelers. But again, I was on a call with the CDC yesterday, and we'll talk about that in a later slide. So I don't have a good answer about traveling. We're still working on that.
Is there a requirement to report COVID vaccine administration to our residents in NHSN?
No, my understanding is that that's completely voluntary.
Okay. Residents who have been exposed to positive staff and are placed in transmission-based precautions, but they are allowed to go out for Easter due to their rights to leave. How is the best way for facilities to deal with this?
Well, that's a really good question. I think that every resident, this has not ever come up before, and I haven't really thought about it, to be honest with you, but every resident has the right to leave. And I'm thinking that if they leave and come back, your goal really is to protect the resident when they're in your facility and the other residents. So I think that you would have to look at the situation when they come back. We're going to talk about returning visits, persons and visits. But I think that as long as everyone understands the rules, I'd probably test them, make sure their family knows that they're a risk. But you can't stop them from leaving, but you can quarantine them on return and screen them for potential exposures on return. Now, I have to say that that was off the top of my head, but that's the way it appears right now. I have not really considered that piece.
Okay. Do we have to quarantine close contact for fully vaccinated independent living residents, or do they follow community rules per CDC, which state they do not need to quarantine if fully vaccinated?
I assume that when you're talking about CDC, you're talking about non-healthcare, but there is a piece in the CDC guidance right now that says that if someone's fully vaccinated, they've had no close exposures, you do not have to quarantine them.
Okay. MDHHS's latest guidance points to CMS, so all residential care facilities, including HFAs and AFCs, now have to follow the CMS QSO, correct?
Yes, but there's a huge but to that, and we'll talk about that later. That is what the written guidance says, and to be honest with you, that's what I would follow. However, we are hearing confusing and conflicting messages from the state, and we're going to talk about that in a minute.
We are seeing an uptick in employees who are exposed to positive children, young people living at home. If fully vaccinated, can these employees still work, or should they continue to follow the 14 days of quarantine?
We're going to talk about that again in a moment. The latest CDC guidance says that they have to be quarantined. Well, let's wait till we get to that guidance, because these does it say, Blake, that they're fully vaccinated?
I need to find that question again. I'm sorry, give me one. It says we are seeing an uptick in employees who are exposed to positive children, young people living at home. If fully vaccinated, can these employees still work, or should they continue to follow the 14 days of quarantine?
To be honest with you, I do not remember off my head what the guidance says about vaccinated or not vaccinated. So let's wait till we get to that section.
Okay. It still does not count as an outbreak if weekly testing reveals a staff positive, but they were not in the building for over 72 hours, correct?
That's correct.
If a resident comes in close contact with a staff member that is positive, the residents will need to be quarantined. Would the resident's roommate need to be moved out, or place both of them in quarantine together?
I would think that they could be quarantined together. They would be part of the affected unit. I don't think that you generally have to put everyone in an affected unit in a private room. I don't even think that's possible. If someone is exposed, I'm assuming that they're also exposing their roommate. It's hard for me to envision, if a person's exposed by a staff person, how their roommate might not be. But I suppose that's possible.
Since fully vaccinated new residents do not have to be placed in quarantine, then if they were to become positive in the first 14 days, does it still not count as a facility outbreak case?
Yes, it still does not count as a facility outbreak case.
The Michigan Executive Summary Letter about Visitation Guidance issued 3/17 calls the actions recommendations. Do you know if we must follow or acknowledge and decide how to apply to our facility and population?
That is, again, another question of the day, and we're going to talk about that in a little bit.
Okay, we are looking at LOA the same as a new admission. If they are vaccinated, they don't have to quarantine. We are going to POC test upon return.
That's correct. That's a good plan.
When people come back, we have decided to restrict When people come back, we have decided to restrict from group and communal dining for a period of 1 week and test them.
The people are coming back from an overnight. There is new clarification. I wouldn't call it new guidance. That if a person's been out overnight, they are expected to quarantine for 14 days unless they are fully vaccinated. Or if they've been exposed and even fully vaccinated, they have to be quarantined for 14 days. Now, that I really never found that written anywhere until the update from the CDC on Monday.
To clarify quarantine of a vaccinated person who has a close exposure, employees can work, but residents would need quarantine?
That's correct.
Okay. Is it still a requirement to disinfect and hold packages that get delivered to residents for 24 hours?
To be honest with you, we have not revisited that. I'm not sure that that's still a requirement. I do know that there's been research in the last several months that says that the chances of transmission from a hard surface are almost nil. But I do not know that CDC has rescinded that guidance, and that's something we can look up.
Okay. And then this one is more of a comment. A federal surveyor I talked to recently said that recommendations mean we should do it.
Well, and that's true. that's something we're going to talk about, but it depends on recommendations from whom. And the state itself came out and said, number one, that the CMS guidance is the written guidance that all of these nursing facilities and nursing care facilities, residential care facilities should follow. You can't follow both of those. You cannot do it. I mean, they're in conflict. And they also said during a conference call that we had with the state a week and a half ago, right after the guidance came out, that those recommendations are meant to be only best practices. However, we have been hearing different messages since then. So that is a lot of what we're going to talk about in a few minutes. And yes, it is extremely confusing. The other thing I want to say before we move on is that there's an awful lot of nuances in this guidance that came out Monday. And I do not have them all cemented clearly in my head, so I apologize for that. In the past, we did a written Q&A to follow up. And I stopped doing that because it was just so repetitive over time. But I think we'll do that again this time, just for the sake of clarity. So expect written responses to all these questions, hopefully within about 24 hours.
All right. It looks like that was the last question, so we can go ahead and move forward.
Okay. So we are going to continue with the CDC updates. They just seem so long, I thought we had to break it up. And this is something that we were just talking about, residents who leave the facility. So the first two bullets haven't really changed. They talk about the resident understanding the safety precautions needed when going out, the communication that's required with other medical staff or those going out for appointments. Persons who go out for such visits or appointments do not require quarantine, but only screening on return. The rules for dialysis patients have not changed, but facilities can consider whether or not there's uncertainty about adherence and through the screening process, make a determination about the need for possible quarantine when they return. So this last part is new, and at least I've never seen it in writing before. That persons who leave the facility for 24 hours or more should be addressed in the same manner as a new admission or readmission. So if that person's unvaccinated, you have to place these persons in a 14-day quarantine. The guidance that I'd seen prior to this really based that decision to quarantine on a screening when they returned for possible exposures. But because now they're saying that persons who have left the facility for 24 hours should be addressed in the same manner as a new admission, it also means that if they are fully vaccinated and have experienced no close contacts, that the quarantine is not necessary for them. For persons with new infections, this was updated a bit, but there's very little new here. Basically, it just addresses the changes in visitation based on the CMS guidance whenever there is an outbreak. The last part of the new guidance talks about asymptomatic staff and residents who are within 90 days of COVID infection. Again, quarantine and work exclusions are not required, but they could be considered in certain scenarios. When there's uncertainty about the timing of the infection, if the person is immunocompromised, if there were concerns the test could have been a false positive, because you're, putting people at risk if indeed they do not have the immunity from being diagnosed as a positive. And the last part is definitely new. If the exposure was to a person who's been diagnosed with a variant, then they do have to be quarantined, even though they've had a positive COVID infection in the last 90 days. So that pretty much ends that CDC guidance. The CDC also updated some of their guidance for group homes for persons with disabilities. We've listed the section headings there. So if this applies to you, you might want to review it, but in reality, we didn't find anything new. I think that the point of this was to do something specific for group homes for persons with disabilities, but there was nothing new or different that we could see. Okay, so last week I listened in, as I usually do, to the Mdhh updates for HFAs and AFCs, and they generally hold this event weekly. And I was somewhat concerned about the guidance offered there because it seemed to be in conflict with what we had heard and known to date. First, apparently, according to that presentation, there's a requirement that if someone goes out for 24 hours or more, that they needed to be tested on return. Now, I guess that's based on an interpretation of their testing guidance, and we're going to talk about that a little bit more in a minute. The thing that probably concerned me the most is that they specifically avoided the option of compassionate care visits when they covered the visitation guidance. And obviously, that visitation guidance right now in Michigan is based on the QSO 2039. So at first, when going through the visitation rules in Michigan, which was pretty much the QSO, when they got to the part about compassionate care visits, the topic was completely avoided. And the only statement was that persons who were diagnosed as positive or under quarantine could receive no visitors. So I immediately, my brain sent up flags, and I thought, well, we're going to have to talk about this. But then later in the presentation, she acknowledged that the QSO allows compassionate care visits, but that Mdhh was still skeptical, and apparently they're talking to CMS about it. The presenter implied, but she didn't state, that they're not allowing it for now, and that the Mdhh document that includes what we know as best practices, the state told us that that document that came out with the order was really only about best practices, but she stated that the department's guidance does not include those kinds of visits. So we were told that this document is true recommendations, not requirements, and that the CMS requirements and flexibilities hold, not just for nursing homes. But apparently they're reconsidering this, and she also said that they're planning on some more updated guidance in the next week or two. So this is a huge issue, we feel, because although there's conflicting rules out there, they also definitely refer to the CMS guidance that's written. The rest are recommendations. We're going to try to get more clarity about this. We are in conversations with the state, but this seems to me a major dilemma, especially when visitation is so important, and end-of-life visitation is so important for persons who are COVID positive and or who are simply being quarantined because they're a new admission. So we're still arguing these pieces. Right now, I believe that the official word that we've gotten from the state is that, one, the QSO is the guidance, and the supporting document are best practices. And I think until we hear officially that that's not the case, the QSO should be applied. But HFAs and AFCs are in a little bit more of a risky area because technically, the state doesn't have to allow them to follow the QSO. And that might be one of the reasons why, because this was an HFA-AFC event that this presentation was at. But we are going to try and clarify this as soon as we can. Another thing that they clarified was the sharing food. If you remember in the core principles or whatever in the earlier executive orders for visitation, it advised people not to share food. Well, I actually thought that what that meant was they shouldn't bring in food. Now they're saying that it's okay for the family to bring in food. They just can't eat it while the visitor's there because of the potential for transmission because there'll be no masks on. So it's really about the masking and transmission and not bringing food in specifically. So lastly, and this last box on the right, is about our concern and confusion about this best practice document. It was issued with the epidemic order. It supposedly, the epidemic order itself defers to the QSO, but it still makes no sense to us that we have words that say recommendations that violate and further restrict the CMS guidance. All of the long-term care facilities are listed as covered under those recommendations, or what they called out to us best practices, and which was delivered with the understanding that there were no requirements to adhere to it. So we're still concerned about all that, and hopefully we'll get some better guidance at some point. Testing on return. So the recent direction from the department was that residents were to be tested on return from stays that cover at least 24 hours. The LARA guidance for HFAs and AFCs does not say that at all. And we can only assume that this interpretation comes from the testing guidance from the Mdhh. It does say that returning residents during intake must be tested, but intake is the word in non-nursing home settings, which usually means admission, not just return from a visit. And it makes no sense to us to test someone who's been out on a single overnight visit, because if they've been exposed, the likelihood of being positive on return is negligible. However, there's no requirement for testing on return from an overnight from the CDC, but the CDC, as of this last guidance, is now saying that persons who have gone overnight should be placed in quarantine unless they meet that fully vaccinated, no exposure exception criteria. So this is the CMS language on compassionate care visits. I just threw it in here because, and we're not going to review it because I think everyone knows it. But the issue really comes down to the HFA AFC presentation or this guidance. And there's nothing written that says that any of the long-term care facilities cannot allow compassionate care visits except for those best practices / recommendations. So we would have a hard time not allowing it, especially when it's so detrimental to the well-being of the residents. So recommendations versus requirements. When the state residential care facility visitation guidance was issued, it immediately concerned us greatly. It didn't even reference the QSO visitation rules, and it uses the word recommendations. As the one commenter said, we know in guidance, recommendations often mean rules, but sometimes they don't. And for this document, the state staff clarified that these were to be considered best practices. So for the time being, we're going to go with that. And again, we're seeking to get more information, especially considering the varying messages that we're getting from the state. So the other thing that we want to talk about before we end today is, well, we have a couple more things. The CDC Travel Recommendations. This came up earlier when last we discussed it. I noted it in our last webinar because it was called out in the CDC update based on vaccinations. So I added the point the staff need to follow the CDC Travel Recommendations. And I'll be honest with you, I didn't look at what they were at the time. However, the CDC guidance, which was not the link to that in their document, is not specific to healthcare workers, but it did state the need for testing and quarantine for 7 days. And it didn't specify whether or not the location mattered. And then during a discussion call with CDC yesterday, they stated that healthcare workers should stay out of healthcare settings for 14 days if they travel out of state or to a high transmission area. So this is another really confusing area, and we're looking for additional guidance on that. A few other updates that are not quite so controversial. The CDC did extend the eviction moratorium through June, and there are some updates in the requirements for that. Persons will not have to file another attestation in order to extend their status, but there is some revised guidance coming. Leading Age has produced a visitation toolkit that includes many resources, including a guide, a set of checklists, and competency tools, and these can be obtained from their website. And yesterday, the president signed legislation that extended the PPP application and processing deadlines. Originally, it was the deadline was tomorrow, but it's now been extended to May 31st and June 30th, respectively. And during the Leading Age call yesterday with CMS, they answered a few questions that spoke to CDC guidance. And they provided clarification, and none of this piece was really new, but it spoke to the fact that when CMS refers to CDC guidance for many of the COVID requirements, that CMS will expect to enforce the CDC guidance as a nationally recognized standard when the recommendations have not otherwise been spelled out specifically by CMS. And that's something that came up earlier. So remember that the CDC guidance supports CMS requirements. Can a nursing home deny entry to a visitor who does not adhere to the core principles of infection? CMS said yes, but they really want to facilitate visitation, and so facilities should take and make efforts to work through the issues, try to make sure that everybody understands the reason and the importance. But if indeed a visitor refuses, then they can be asked to leave. Can residents who are unable to wear a mask have physical contact during a visit? So this was a very flexible answer, I found. Residents who are unable to wear a mask would ideally be vaccinated, but not necessarily. And they would warn against physical contact. However, the CMS specifically said nursing homes are not expected to police these visits. The nursing home should make sure that the resident and the visitor knows the safety precautions, including the importance of masking and source control, but residents have the right to privacy during visits. So there is some, resident right issues here. Lastly, the CDC, through Leading Age, is looking for creative ideas to prepare for working with long-term care pharmacies that retail pharmacy plan to vaccinate residents and staff on an ongoing basis. This is for some long-range planning. So they are looking at, actually they're asking for creative ideas from providers and from Leading Age. So if you have ideas about issues, problems, etc., you can send them directly to Leading Age or send them to us and we'll forward them to them. But they are calling for some ideas there. So, thank goodness, that's all that we have today. Again, a lot of new guidance, or at least nuanced guidance, a lot of conflicting areas. We will send out a written Q&A response following this webinar.
All right, thank you, Deanna. We do have a list of questions here, so I will just pull them up. Give me 1 second. Okay, we received confirmation from IPRAT Mdhh that if it is not an outbreak, if staff has not been around residents or other staff in previous 48 hours, so you don't have to stop visitation or do outbreak testing.
Good, great, that makes sense.
How/what test determines if COVID positive is a variant?
The state health department does the variant testing. I am not sure of the mechanism of how they report back. I would think that there would be some notification about that, but we'll ask the state specifically. The state pulls a certain number of tests that have been done. Well, this is a good question because point of care tests don't go anywhere. They would have to be PCR tests. So if you have a confirmatory PCR test, the state will pull from the lab the sample and do some retesting. Point of care tests, you will never know.
So do we move forward with compassionate care visits if we have recently had 2 positive employees?
Well, assuming, yes. Well, first of all, compassionate care visits are always allowed for anyone, independent of which guidance you're following, if they're not COVID positive or in quarantine. If they're COVID positive or in quarantine, CMS says you can allow compassionate care visits as well. If you're in the middle of an outbreak, it depends on the affected area. So you cannot have visitation in an affected area during an outbreak. Now, if you've identified that the visitation, that part of the facility is not affected, and all of the residents in those areas are continue to test negative, you can allow visitation in those areas.
Can we bring animals back into our facility?
I've not seen any guidance about that. I do know that some facilities have allowed animals in. I don't know of any specific guidance. We'll have to look into that.
If an employee is fully vaccinated and has exposure to COVID-19 positive person, are they able to work without a 14-day quarantine? If it is the variant, they cannot work. How do we know the difference when someone states they have had exposure?
Well, that's a logistical question and potentially a problem. I guess you technically should include that in your screening or your investigation, if you would, about the test. But unless the state itself has done a variant test, I would assume that the state would inform the positive person. So the best you can do is ask your staff or whoever.
Is there further guidance on travel for vaccinated healthcare professionals?
That, again, as I said before, I'm looking for that. I've not seen it yet. I'm hoping to find it and or get clarification from the CDC.
CDC Travel Recommendations should be amended for fully vaccinated people. That was more of a comment. In a staffing mitigation crisis, when an employee may have had exposure, what is the minimum number of days an employee must be quarantined? At one time, it was 7 days.
Prior to this recent guidance, my recollection was that it depended on the exposure and the kind of exposure, and there was a page in the CDC website that identified levels of exposure. And for basic exposures that were not close contacts, were not really prolonged, that had PPE involved, there really was no work restrictions. But depending on the level, if it was a close exposure, then there were restrictions. I don't remember the days. I don't remember 7 days. But we will look into that and provide a written answer.
CDC Travel Guidance has recommendations for travel in states to follow your local state guidance for travel. Michigan has no mandatory quarantine period post-travel, correct?
I've not seen any travel requirements for Michigan. So as far as I know, no. But That's not what the CDC person said for healthcare persons yesterday on the call. They said that if you're traveling out of state, you need to be quarantined for actually 14 days before you go into a healthcare setting, because healthcare settings include vulnerable people. Now, I know and understand, and I think that I've never felt like there were so many nuances and conflicting pieces of guidance as there are right now as time moves on. But we will just continue to try and work to get to the bottom of these things.
How do we reconcile SNFs being required to keep COVID-19 out of the facility but are not expected to police visits and have the right to privacy during visits? Strict liability questions on this will absolutely need to be reviewed in this context.
Yes, there are a lot of dilemmas here. I have to agree. And maybe it's time for us to perhaps convene some of our legal friends to talk about some of these issues moving forward. Plus, I'm always a little leery about, well, I'm less leery when I have a CDC person talking to me directly, but a lot of the things that we get are not in writing, and I'm always not comfortable when I can't see it black and white.
If a CNA calls me and says her mom tested positive for COVID and she was around her yesterday, does the CNA have to quarantine for 14 days?
That's my understanding.
How are we realistically supposed to follow the CDC travel guidance? Do we just tell staff they can't take a vacation? We already have a hard enough time with staffing, and if we tell them they can't take a vacation or have to quarantine for 14 days after and use all of their PTO, many will just quit.
I agree with that, and I actually think that this is a little untenable because it wasn't what we have been hearing before. And with the decreases in transmission, now granted we've had some spikes, but with the decreases of transmission over time, the travel pieces have not really been a subject for, at least not for staff that I'm aware of. So all of a sudden the fact that this is coming out again now, I'm not sure. It might be based on the upswing in cases, but we need to get better clarity. So I'm not sure that I would change anything until I heard and see something in black and white.
We have had only staff test positive and the area where they work is considered an outbreak. Can we immediately reopen that area if our outbreak testing shows no other antigen positives, or do we have to wait for PCR?
You don't have to wait for PCR, but you do have to, if I understand the question correctly, I may not, but if you have had staff test positive, I don't know if you're talking about PCR resident testing or PCR staff testing. If you have confirmed positive cases in your staff, whatever their contact area is, that is your affected area. And you cannot open that back up until you have had no positive cases in 14 days. If during your serial screening based on the outbreak of residents and staff, you only have cases in the outbreak area, you can open the unaffected areas and make sure that you're confining staff and residents to the affected area. But you cannot open the affected area until 14 days after the last positive.
How quick is the turnaround with the state to know if it is a variant?
I do not know that, and I also know that they may not even do the tests right away. So if you don't hear that it's a variant, I would assume it's not a variant. I mean, there are quite a few variants in Michigan compared to other states, but there's not that many.
We have no COVID cases or suspected. Is it okay to wear K95s?
My understanding is right now that the requirement for N95s in general, except for one conflicting piece from MDHHS again, but in general from MIOSHA, the CDC, and CMS, is that you only have to wear an N95 for suspected or COVID positive cases, although you might consider going to N95 if you are in a community of really high transmission. But technically, a face mask and N95s will do.
Can you confirm if a healthcare professional is vaccinated if they should not have to quarantine with a positive exposure?
No, I'll have to look into that. I cannot say that. Positive, and again, it goes back to the level of that exposure. If they had a real exposure, a close contact exposure, more than 15 minutes, in the vicinity of someone within 6 feet, without any PPE, I'm thinking that they do have to quarantine, but I will check into that.
Okay. So it does look like that was actually our last question. So if you do think of anything after the webinar has concluded, as always, you can email Safe and Calm, Dalton or Deanna at leadingagemi.org, and we will make sure to get those questions answered for you. So at this time, we would like to thank Matt and Nancy and the OmniCare team for joining us and helping us answer some questions today. We would also like to thank Dalton and Deanna. And lastly, we would like to thank the 95 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, that will be the conclusion of today's webinar. I hope everyone has a great remainder of their Wednesday, and we will see you next time.
And this is Deanna. Please remember that we will send out a written Q&A. We will try to resource each question as best we can in terms of references. Do please keep the questions coming because that's what spurs us to try to work to find the right answers. So thank you and have a good day.